we'll talk about the 4 different types of hypersensitivity. I always remember it with the acronym ACID. So type 1 is anaphylactic, type 2 is cytotoxic, type 3 is immune complex mediated, and type 4 is delayed. Now, you need to kind of know the other names for them as well. So, right, anaphylactic, that is your classic allergic reaction. People have anaphylactic reactions to things like peanut butter, all that stuff, right? This is immediate. Think about that. When someone eats peanuts, you need to administer an EpiPen as quickly as possible. Because if you don't, things like their throat closing up will follow, right? Especially if they're severely allergic. And we'll talk about some of those manifestations later. But for now, let's talk about type 1 hypersensitivity, which is basically the mechanism I just explained to you, right? You have exposure to an antigen, right? The allergen will enter your body. Now, your body misinterprets this allergen as something like a bacteria. Okay, we need to mount, or we need to get used to what this looks like, so if it ever comes back, we can attack and kill it as quickly as possible, because it deems it as dangerous, even though it's not. This is why some people are allergic to things like dust, and some people are not, right? If my body is overreactive to it, I have a hypersensitivity reaction, you may not, right? Basically, your body is going to prime its immune system to respond to this, right? So you had, in microbiome, when you guys didn't get taught anything, you had T cells that mature in the thymus, and then they end up entering circulation. And now before those T cells meet any sort of antigen in circulation, they are called naive. They are almost waiting for an assignment, right? When those naive helper T cells find this antigen that dendritic cells present, right? So allergen enters, dendritic cells grab and go, hey, look at this. The naive T cells come around and say, okay, let me scan this, get an idea almost like you're making a mold of what the antigen should be, and now your body makes antibodies against it, right? And it does it through a bunch of different cytokine production. I don't know if he's going to ask you for the exact cytokines, but for type 1 hypersensitivity, you need to know 4, 5, and 13.
I'm sorry, repeat that, please.
4, 5, and 13.
No.
IL.
Those are the
Those are the cytokines involved in type 1 hypersensitivity. IL-4, IL-5, and IL-13.
This is just hypersensitivity 1 there.
This is hypersensitivity type 1. 13.
These are, what are these again?
Cytokines.
And they do what?
So they signal certain pathways in your body, right? So I don't think you guys saw a picture of it, but basically in your bone marrow you have hematopoietic precursors, which are responsible. They will become your white blood cells, they will become your red blood cells, they will become your platelets, they will become everything. Where they go in that pathway of maturation and specialization, if you want to call it that, depends on the signaling molecules. Cytokines are signaling molecules. So they tell your body, okay, right now we need these, make these, right? And the specific thing that you're making in response to this allergen and the type 1 hypersensitivity reaction is IgE. Remember that IgE is the major immunoglobulin that is attributed and utilized in a type 1 hypersensitivity. IgE, right? So what this IgE does is you have mast cells that are circulating in your body. The IgE will basically coat the outside of it, right? And now remember, these IgEs are able to detect the specific antigen from the pollen or the allergen, whatever it may be, right? That specific antigen. When the body recognizes it, those IgE molecules on the outside of the mast cells, those are what recognize it, right? So they say, hey, we saw this before, we know what this is. And what they do is they activate the mast cell, and the mast cell breaks down. And when that mast cell breaks down, everything that was inside of it comes out, right? Those things that are inside are called mediators. Now you have some that are preformed, made, and ready to react. This is why it's a mediator. Because as soon as you detect the antigen, and that IgE activates, and that mast cell breaks down or degranulates, histamine is released. It's already made. It's waiting there, right? It's like a water balloon. You pop it, the water pours out. In this case, the mast cell, you're breaking it, and now the histamine rushes out. We talked a little bit about histamine. Two of the major things it does are increased vascular permeability and increased vasodilation, right? Those are what we talked about when we discussed inflammation.
Increased vascular
permeability and vasodilation. Because you're trying to get things out of the blood to the site where the injury or the allergen is, and you're trying to get more blood there to begin with, so you vasodilate. Now you also see a couple other things like bronchoconstriction or mucus secretion, right? Think sometimes when you have an allergen, it gets harder to breathe, right? You wheeze a little bit. On top of that, your nose gets really stuffy, right? That's your mucus secretion. Just think pretty much all of these. So you have the ones you need to know based on inflammation, the vascular permeability and the vasodilation. Everything else that presents with a type 1 hypersensitivity reaction is what you understand as allergies. Your nose gets stuffy, your eyes get runny, it's harder to breathe, your throat gets scratchy, right? All of these things. That is your type 1 hypersensitivity. That is your allergic reaction. There are second mediators, or secondary or lipid mediators, and those are released, and the point of them is to prolong your inflammatory response. Right? So the histamine gets it started, it makes sure that you have inflammation that brings more cells to the site of the infection that the body thinks it is, right? And you'll release things like leukotrienes, PGD2, and then other cytokines. All of those things will again stimulate and start certain reactions of the body. And now we get into actual systemic classification or clinical symptoms, things that we see, right? So all of that was to explain the way the pathway happens. Does all of it make sense in that capacity so far?
Yes, you did a better job of explaining it.
First mediators, like specifically.
Specifically, your preformed mediators, the one that you need to know is going to be histamine.
Oh.
Histamine is the most important one. Now, there's a couple other ones, I think, amongst the other ones that are important. I would say that the most important one would be heparin, and heparin is an anticoagulant.
It's what?
It's an anticoagulant.
No, what is the word?
Heparin. Heparin.
One last time? One more time.
Heparin is an anticoagulant.
Would you mind spelling it one more time, please?
Heparin.
Heparin. Thank you.
Right? And the reason you need an anticoagulant in this case is you want the blood to get there, right? You don't want it to be trapped inside the vessels, because the body interprets it as something that it's not. So, now you get into the actual manifestations that you may see in someone that experiences it. So, you can either have systemic anaphylaxis, or you can have localized. So, systemic are going to be the things, if someone has a deadly allergic peanut allergy, right? Imagine what happens.
Their throat closes up and they start to choke.
Their throat closes up, they start to choke, they may get scratchy, they may get a rash, things like that, right? So you see itching, you see hives. He probably wants you to know the fancy term because he's always difficult, and that is urticaria or urticaria. I'm not exactly sure how he pronounces it.
Urticaria.
Yeah, something like that. But, so you,
What is that?
hives. It's just a really fancy way to say a skin rash. But he likes fancy things. So. Sorry, I realized I forgot to do a 10-minute song right there real quick.
I am present.
Are you sure?
Spiritually and physically. Therefore, I am here.
Okay. So we have itching hives, you have a bronchospasm, right? And on top of that bronchospasm, you also have increased in mucus production. Think this is why it's getting hard to breathe. Your bronchioles are spasming in your lungs, right? You may have abdominal cramps. The two that are really important here that I think will be the two that he asks about are going to be your laryngeal edema and your vascular shock, anaphylactic shock, which I'm sure you guys have heard before, right? Basically, right, think about two of the more extreme things you see happen if someone has an allergic reaction to something. Their throat closes and they can't breathe, or they pass out, right? Now they're non-responsive. So, throat closing is due to laryngeal edema, right? If you remember what edema is, it's the buildup of fluid. Basically, the fluid builds up in your throat so much that it stops, or it compresses and constricts the vocal cords. You get laryngeal obstruction, and eventually you die, right? Because you can't breathe. That's your throat closing up. The other one is going to be your vascular shock. Well, if you remember, the mechanism for shock was your blood pressure drops so much that you can't supply it to enough spots in your body, and now you die.
Was that one again?
Shock.
Fifteen drops.
So shock is a massive drop in blood pressure that prevents its delivery to certain regions, specifically the heart and brain are what needs it the most, right? So if you think, remember what histamine does. It's a massive vasodilator. If you dilate the blood vessels, what happens to the blood pressure within them? It drops, right? So because of the massive amounts of histamine you lose at the start of an anaphylactic reaction, you can now not have adequate blood flow to regions of the body because of that decrease in pressure. Now those are your systemic, right? This was your entire body was affected. That's why you couldn't breathe. You couldn't deliver blood anymore. Now you pass out. You die, right? Now you have local reactions. This is specific areas. If you're allergic to a dog, where they scratch you welts up, right? But nowhere else in your body really has an effect at that point. Now, if you sit where their hair is for too long, now you start seeing those systemic effects, right? But for local reactions, typically what we're going to see is you're going to see the same thing, hives. Specifically here, hives are going to be in one region of the body, as opposed to running down the entire arm and across the chest. Now it might just be on the palms of my hands where I touched the dog, or maybe it'll be right on my forearm where they scratched me. Hay fever, which is a misleading name, and it makes it sound like this big scary disease. Hay fever literally is just your nose runs and your eyes get watery, right?
Isn't hay fever just allergic to grass?
Yes,
Okay.
anything.
So he
Not
went,
just hay.
he went on
not
at length
just
about
grass.
it. He went on at length about it just not being related to hay or fever.
It's a
So
stupid name.
it is, but still.
But think, you're allergic to cats. You walk into your friend's apartment who has a cat. Your eyes start running, your nose, you start sneezing, you need to blow your nose, all of those things. So you have allergic rhinitis and conjunctivitis. Let's go back to our breaking down words into their pieces, right? So allergic, it has something to do with allergies, which tells you immediately this is type 1 hypersensitivity. Because that was the A in acid, anaphylactic or allergies, right? Rhinitis, rhino. Think about when you get a nose job, the correct term for a nose job is a rhinoplasty, right? Rhine or rhino is the root word for nose. So when you get allergic rhinitis, you are having allergic inflammation because of the suffix itis of the nose. And in allergic conjunctivitis, you're getting allergic inflammation because, again, itis of the conjunctiva, which is a part of the eye. So hay fever is just a way to say that my nose got runny and my eyes got watery.
Is that allergic rhinoconjunctivitis?
Allergic rhinitis and allergic conjunctivitis.
So rhinitis?
Yes. So rhinitis is the nose. Now,
Think of a rhino.
a rhine,
Yep.
right on top of
The
the
nose, runny nose?
runny nose, stuffy nose, sinus pressure, stuff like that. You might sneeze.
The second one?
And then the other one is allergic conjunctivitis. That has to do with the eyes. The conjunctiva of the eye is inflamed, hence the itis, and it's because of an allergy. Now you can have a couple other things. You can have bronchial asthma. This is specific to the bronchioles, right? You may have your throat not closing up like we saw in the other one, but here you just maybe you cough a little bit, right? Maybe you start wheezing. And then you have things like diarrhea or contact allergic dermatitis. Diarrhea, whatever. I mean, sure. Contact allergic dermatitis, I hate the fact that he brings up because that's a type 4 hypersensitivity reaction, so I don't understand why he mentions it in this slide. and I'm not in his lecture, so I don't know what the fucking reason he gives us. But
I have his lecture recorded if you want that.
I'm gonna skip by this one because we'll talk about it when we get to type 4 because that's the reactions. So that was type 1 hypersensitivity. So remember, type 1, the A in acid, it's anaphylactic, it's allergic, and an important thing to remember that isn't the A is it is immediate. Right? These are the things that happen instantly, and it's because of the fact that your body is predisposed to it. Right? Remember, you had those mast cells coded in IgE specific to a certain allergen. When that allergen enters the body, your body reacts. Does that make sense regarding type 1? Perfect. Now you have type 2. Now this is your cytotoxic. He calls it antibody dependent or antibody mediated, right? So, for this one, you have antibodies that are directed against antigens, as you did in the last one. Remember, antibodies are always targeting specific antigens. In this case, these antigens are on the surface of cells or embedded somewhere, right? Again, the antigen that is being targeted is embedded somewhere, usually in a cell membrane is what we're going to focus on, right? So the antibodies will detect those antigens, it will go to them, and it will mount an immune response. Now this can be some sort of bacteria that's embedded itself in a cell wall. It could also be autoantibodies, which are
The-
antibodies formed against self.
Gotcha. The antibodies are embedded in the wall, or the
The
antigen?
antigens
Okay, antigen.
are
Okay.
embedded in the wall. The antibodies come and detect them. So there are 3 of these antibody-dependent mechanisms.
Embedded in the walls of what?
Cell membranes, usually. So he calls them antibody-dependent or antibody-mediated. That will definitely help you understand the mechanism behind it because we're focusing on the antibodies, right? I'll explain to you why I call them cytotoxic when we get there, right? Our first one is going to be complement-dependent reactions. So, a complement is, it requires an antigen to bind to an antibody first, right? So remember, antibodies are specific to antigens. When an antibody gets close to an antigen that it is specific for, it will bind to it. They will connect. Upon this binding, it forms an immune complex, and that complex will trigger a complement pathway. So, that complement activation, that complement pathway, is started with the goal of killing whatever activated it. So that would be the antigen. Specifically now it's a complex. It's an antigen-antibody complex. It's an immune complex. Right? Now, when you activate this complement-mediated cytotoxicity, which is the mechanism of killing it, right? You're trying to destroy it. You have 2 ways it can happen. You have direct lysis, and you have opsonization. Most of the time, type 2 hypersensitivity reactions will end with the antigen being destroyed by either direct lysis, remember lysis is breakdown, right? So you're directly breaking it down, or you're opsonizing it. If you remember what opsonizing was, I think you guys talked about it in biochem a little bit, and then microbiome. Opsonization is basically just a flag, right? Think about a cell going around and marking the cells for destruction. That is opsonization. So your immune system will say, hey, something's not right here. Y'all got to come kill this. And then it'll go its own way. And that cell will then be marked for death or phagocytosis. Did you have a question?
Would you mind spelling that word?
Opsonization.
Yeah, that one.
O-P.
O-P.
S-O-N.
S-O-N.
I-Z-A.
I-Z-A.
T-I-O-N.
T-I-O-N. Optimization. Thank you.
Opsonization. So, you have those 2 pathways. Direct lysis is going to be when you have the complement form a membrane attack complex, and it will punch holes in the cell. So, you have cell membrane, right? You've talked about this since like high school chemistry. You have a phospholipid monomer, right? And it exists like this. Everything's facing each other. Now, what we're going to say is you have some sort of antigen that ends up placing itself here in the cell membrane, right? So now what happens is you have your antibodies that are in your body that will say, hey, I'm supposed to go here, right? I know him, I recognize him. So now that antibody will combine with the antigen and form an immune complex. That immune complex forming also triggers more immune reaction from upstream, right? So now this is your complement pathway. So one of the things that can happen is your body will send a cell wall, almost like an excision unit, if that makes sense. Like it's a membrane attack complex. So it will basically come and it will say, okay, it is somewhere in here. And it will take this whole chunk out of the membrane. It'll go, all right, this chunk, gone. That's a membrane attack complex, right? Well, guess what? In that process, the antigen's gone. So it worked. Now, this especially helps when you have a cell that's been infected and the antigen on the surface is because of the infection, right? So that cell a lot of the times will rupture because you're taking a piece of its cell membrane out. So direct lysis, you have a membrane attack complex that punches holes into the cell membrane. Opsonization is like what I said, you mark the cell for phagocytosis. You say, hey, this one's got to go, and now your body knows, okay, this is the cell that we are coming to attack, and it will come and attack. Now, there is a pathway that can occur called frustrated.
Is this direct lysis that you just showed us?
What I just showed you was direct lysis, yes. So opsonization, what it would be, is you'd have that antigen again here, right? And your antibody would come and bind to it, and then you would just do something like, okay, come destroy it, right? And what would happen is some sort of cell specialized in phagocytosis will come, and it will eat it. And then it will destroy it on its inside, right? Now, you can have something called frustrated phagocytosis occur when the cell is too large to phagocytose, right? This is the basis of a couple different autoimmune reactions that happen. Because what happens is the complex is deposited into the cell membrane. Your body comes in and says, okay, we're going to phagocytose this, and then your phagocytosis molecules come, and they're like, all right, I'm going to try to eat this, but it's too big. You can't take the bite, right? So instead, what they do, since they know they're not able to phagocytose it, they will simply release enzymes and things that will help kill it, right? All right, we can't do it this way. We're going to try something else. Rather than me envelop the whole thing, I'm just going to secrete things to kill it. Now, this is nice, but it's not specific. So those enzymes, a lot of the times, will not only kill the antigen, but it will kill the surrounding tissue. And that's something you saw in IgA nephropathy and a couple different kidney conditions. He talks about hemotransfusion reactions. So hemotransfusion, think blood transfusion, right? Hemo, blood, transfusion is transfusion. If you are incompatible with the donor, right? This is why you have blood types. This is why blood types are so essential. If you're incompatible with the antigen on the surface of the red blood cells you are being donated, your body will recognize it as foreign and attack it. And it will break down those red blood cells. That's hemolysis. Hemo, blood, lysis, breakdown. You're breaking down those red blood cells. That is a form of type 2 hypersensitivity. The one that he goes into more detail about is going to be the erythroblastosis fetalis.
Yes, that was very amusing.
And this is Rh positive, Rh negative, which you guys have probably heard a couple times, but probably not fully understood because they never really give you a lot of details regarding it.
So, erythro.
Erythroblastosis fetalis. You want me to write that, please?
Or just like spell it out.
Let's see if I can do it without looking. Erythroblastosis. Fetalis.
That was fun.
I forgot the page. I almost had it. Because it's just like erythrocytes, blastosis, fetalis. So basically, what happens here is you know about blood type in terms of A, B negative, AB positive, O negative, O positive, all that stuff. So there's an additional component you need to think about when you're talking about maternal antibodies and fetal red blood cells, and that is Rh or rhesus antigens. So your blood cells are either Rh positive or Rh negative, but they are incompatible with each other. So if you have a fetus that has blood cells that are Rh positive, but the mother is Rh negative, there are going to be complications. However, there are only complications if there was prior exposure. So, blood cells should never cross the placenta into the mother, right? So if I have a fetus that has Rh positive and a mother who's Rh negative, there is no immune reaction occurring because your immune system, the mother's immune system, is never exposed to the Rh positive red blood cells until birth or miscarriage. Now, when one of those two things happen at the end of that pregnancy, right, that is when your immune system is exposed to something it recognizes as foreign, and now it is prepared to attack it. So basically, you could have your first child Rh positive as an Rh negative mother and never realize it because your immune system does not react adversely to it yet. But if you tried to have a second kid and that child was also Rh positive, this is when you'd see that happen, right? Now, why? And that's because there's one immunoglobulin that is involved in this sensitization that can cross the placenta, and that is IgG. What we were taught when we were doing Irene Golden studying was G, thanks mom, IgG. It can cross the placenta into the fetus. And now because of that, that IgG can attack the Rh positive fetal blood cells. That's not good.
So it attacks the fetus or it
It
attacks the mother?
attacks the blood cells of the fetus.
Kill
Not necessarily.
me. Ooh, okay.
So it is possible that they can live. It's fetalis, it's not fatalis. Right?
Oh.
Fetalis is in a fetus. Fetal.
Oh, okay.
Can I read you what I wrote?
Yeah.
I said Rh mother is fine until birth, and immune system recognizes Rh negative, the body will start to fight it. IgG can cross the placenta in a fetus. These can attack blood cells of Rh negative fetus.
Usually it's Rh positive, but yes. Rh positive fetus.
So,
At the very end, you had it.
so switch the Rh positive mother to the Rh negative mother.
Yes. That's the example I wrote. I'm sure it works the other way too.
Yeah, I mean, we're gonna keep
But
it
for
out.
consistency's sake.
Basically, let's think about this. I don't know if you guys talked about hemolytic anemias or not. But basically, you have lysis of the red blood cells in the fetus. Now you see some things that end up occurring because of it. So, when you break down red blood cells, do you guys remember the pathway?
Yeah.
So, red blood cells contain hemoglobin. So, when you break down red blood cells, you get heme and you get globin. Do you remember what the globin does? Globin gets recycled.
It gets
We just reuse it. Now the heme is the important part. The heme gets split again into two things. It gets split to iron, and it gets split into a porphyrin ring. The iron, again, gets recycled. Nobody gives a shit. The porphyrin ring becomes biliverdin, which is a pigment, a green pigment. The way you always think about this is when you bang your knee, you get a bruise. And the bruise changes colors. At first, it may be a greenish blue color, and then it becomes yellow over time, right? And that's the different pigments within the red blood cells that are being created and transitioning.
Billy
Right.
Verdon, you said?
Billy Verdon is the first thing.
Gotcha.
Billy Verdon becomes Billy Rubin, but that's unconjugated, so now it has to travel to the liver. Then the liver conjugates it, and then you excrete it, right? For now, the big thing you're thinking of is the fact that you're breaking down red blood cells in the fetus. That means you're overproducing things like Billy Rubin. Well, the condition characteristic of an overproduction of Billy Rubin is jaundice. It's when you turn yellow, right? The first thing you look at is the eyes, because it's a little bit harder to see on the skin surface until it gets really severe, whereas the eyes are stark white. So as soon as they start turning yellow, you can tell, right?
You said this is jaundice.
That's jaundice.
That's coming, that,
The baby is born with it.
yes, so from this, like, from it attacking the blood cells of the fetus, then it'll, break down into Billy Verdon, and then, so all that gets
Builds up in the baby.
builds up and turns into jaundice.
And the baby ends up popping out yellow, which is characteristic of jaundice.
And you said it has a stark white sclera.
So the sclera is usually stark white. That's the white of your eyes, your sclera. But your sclera will turn yellow, just like everything else. But in an adult, the first place you look for jaundice is the eye. Because
Okay.
it's easiest to tell, okay, that's yellow and it's not supposed to be. Whereas it might be harder to tell that, even though I'm pretty fucking white, it might be hard to tell that I'm turning yellow, right? Until it gets bad.
I think I know the song about
I was
So-
born with jaundice.
What's up?
I was born with jaundice.
Really? There you
That's
go.
what I'm half deaf.
Oh,
Yeah, it leads to deafness.
interesting. It's not that it's cool, but it's kind of cool.
Yeah.
That won't be on
You
the
know what
quiz,
I
will
mean?
it?
So whenever it gets brought up, I'm like, I know that one.
Yeah, he's a pro.
One thing I know about pathology is jaundice.
So this is going to be, you see autoimmune hemolytic anemias, agranulocytosis, and thrombocytopenia. Those are
Oh
really
my
big words that all pretty much mean the exact same thing. So anemia means you do not have enough red blood cells. If you have hemolytic anemia, it's because you are breaking down red blood cells. Now you don't have enough. Agranulocytosis. What's up?
Can you repeat all those words that mean the same thing again?
So hemolytic anemia, if you break, so anemia refers to a condition of the body in which you do not have enough red blood cells.
Yes, you said autoimmune something anemia, hemolytic anemia, then thrombo something anemia.
So hemolytic or autoimmune hemolytic anemia, autoimmune agranulocytosis, and autoimmune thrombocytopenia describe the same sort of things regarding three different molecules.
It's clots. It's clots, isn't it?
Thrombocytopenia is platelets. So, hemolytic anemia means you are actively breaking down red blood cells, and it's resulting in you not having enough. Agranulocytosis means you do not have granulocytes. Granulocytes are white blood cells. And then thrombocytopenia means you do not have enough platelets. Basically, all three of these are describing an autoimmune condition in which you create antibodies against blood cells. Not just red blood cells, but your white blood cells, your granulocytes, and your platelets, and that's when you have thrombocytopenia. Your thrombocytes are platelets, right? You okay?
Yeah.
Good. Then you have drug reactions, right? So now you can have an antibody directed against a particular drug, but that drug might end up being on the surface of a cell. And now the drug antibodies recognize the cell as the antigen and will attack the cell, right? And then you have pemphigus vulgaris.
You said pimp?
Pemp, P-E-M-P, Pigus, H-I-G-U-S. Pemphigus,
What about you? 16?
something like that.
What the fuck?
So drug reaction is cell attack because the antigen is recognized as the cell, or the cell is recognized as the antigen.
Drug enters cell membrane. Cell membrane now has drug antigen. Body recognizes drug and attacks whole cell. So for pemphigus vulgaris, you have autoantibodies, which are, again, antigens, or antibodies made against self-antigens, right? Making this an autoimmune condition. Basically, you're attacking desmogleins, and those are proteins that connect skin cells. So, if you're breaking down things that connect skin cells,
I don't think he said good desmogleins in his lecture.
what do you think he said?
I don't.
Desmosomes?
Something like that. I don't recall that word being mentioned.
Are you on 17 now?
I'm at the very bottom of my doc. It says week 9 lectures combine all pathologies.
You said desmogleins or what?
Desmogleins. So those are proteins that connect your skin cells. So think of your surface.
Yeah, okay.
Almost imagine that the surface of your skin is a bunch of scales, like an alligator. But think, on the alligator you can see the ridges between all the scales. For us, they would be so tiny that you can't see them, but those connections are made by desmogleins. Now, if your body is attacking those desmogleins, the connection between your skin cells will be broken, which will cause things like blisters or open sores, right? Now, when you look at something like this histologically, right? So if you look at the tissue at a microscopic level, it's known as acantholysis. And acantholysis is that dissolution of the bridges, which are the desmogleins, right? Now, we don't see it on the surface of your skin until it's so severe that it causes something like a break or a blister. But if I looked at your histological tissue at a very microscopic level, I can see those bonds being broken before it ever manifests as something like a sore, right? And he has 2 pictures. The second page of pictures is horrible. Sometimes classes make me want to fucking yap. What?
He makes money at
Also fair.
low food.
Little Putin's crazy.
Yeah, he threatened somebody with the KGB last quarter.
Of course you did.
It's him bringing up the USSR all the time.
God forbid he misses home.
You should ask him how it feels that the wall got knocked down.
My mother has a part of that wall.
I'm gonna ask him. If I go to class, that's why the wall got knocked down, bitch.
It's your fault.
One of the guys, so yesterday there was a guy who came and talked to Dr. Cohen, and he had Bordini like 15 years ago, 16 years ago. And he was in the class, and then he failed because he was tied up with so many other things. And then he was in the class again, and after like 6 weeks, he had to withdraw because his wife was about to give birth. So he withdrew. So then he came back, and he was in it again. And Bordini was like, God, what are you doing still in this class? And he was like, dude, give me a break. I'm sitting in the back. Like, leave me alone. I just had a kid. Like,
You know, but he called me up by name today. He knows my first name.
oh boy.
Nobody knows my first
What did
name.
he do?
My
No,
pencil
I don't
was.
hear you say. I don't hear them tell
He
me what
walked
you did.
out the classroom with a pencil in his hand. That's all he did.
Did you let the door
Was
slam
that
behind
while
you?
I
The door was held open by the trash can.
Was that when I was gone?
He said, John, what are you doing? My pencil's dead. He said,
I didn't say like that. I actually answered it in his accent or his dialect. Said pencil broken.
He said, gotta bring new pencils.
It makes you feel better. When I was sitting in line to sign my name, he was like, why were you late? I was like, I wasn't late. I took the quiz, you started lecturing, I left, and I came back.
I bet he loved that.
I said, I had problems registering, okay?
Man, a lot of people did.
God, I hate registering.
So, we were talking about type 2 hypersensitivity. We talked about the first one. The first one was your complement-dependent cytotoxicity. So this was the direct lysis or the opsonization coming from a complement activation. For the other 2, you have antibody-dependent, because again, these are antibody-dependent reactions, cell-mediated cytotoxicity, and you have antibody-mediated cellular dysfunction.
So antibody-dependent, cell-mediated
Cytotoxicity,
cytotoxicity, and
antibody-mediated cellular dysfunction.
Have you ever put these in like, notebook LN and make like questions from it?
My notes?
Yeah.
No, I haven't, but it's not a bad idea.
You just had enough like, what I'm listening.
I'm sure shit.
I put it into the chat. And then
Notebook
also
I'll tell you what.
submitted
There's
some of
this
his
new
old
one called
exams.
Study Fetch
Oh yeah, I've been doing
that I've seen all over the fucking internet, and I was like, all right, let me look at this, and I bought it for like a month, and it was $20, and it's like $80 for the year, and you can do a tutor session with an
Yeah.
AI, and it will ask you so explain this to me, and then you have to like say it.
So it's like actual AI, not just I.
Yes,
If you're like legit talking to a computer, I think
it's
that's
weird,
smart.
and it's like going through the slides with you and shit. It's like, bro.
I
stop
used
talking.
it for I used it for Gross One's exam one, and then they never.
What is the name of this thing?
Study fetch.
It's got a little white dog.
Yeah, but for this class, I don't think it's gonna help because
Sometimes it does.
I don't know. It went into detail with granulomas, and I was like, "Can you explain that more?" And it will tell you like what it does, and then
Lord.
yeah, but is it on the sign up link? Because
I submitted his documents.
Really?
Yeah.
Oh, I'm doing that.
So
$20
for a month.
for a month.
Yeah, it's $20 for a month.
This class isn't gonna last a month. It's only gonna be a couple weeks.
Fucking ball. 2 weeks. Fuck it.
Antibody-dependent cell-mediated cytotoxicity. So this is going to be antibodies that bind to the antigens. Now, when you have antibodies that bind to it, remember antibodies look like a big Y.
So the antibody-dependent what now?
Cell-mediated cytotoxicity.
Okay, I thought those were two things. Gotcha.
And we're still on number 2.
Yes. It's short though. Basically, your immunoglobulins and your antibodies, which are on the immunoglobulins, always look like a Y. Right, like a capital Y. Each one of those legs, if you want to call it that, has a different name. One of them is called the FC portion. So what happens here is when the antibody binds to the antigen, that FC portion from the antibody is the one that's sticking up into the air, right? And that's what immune cells will come along and recognize. Now, these are non-specific, right? We talked about antigen-antibody binding specifically to things and causing complement pathway activation.
Is that like FC? Is that like a flag?
Not necessarily. So, right? Every immunoglobulin and every antibody is like this shape. I guess you could rotate it and I'll be right no matter which one of these I label. But like that is what we're going to call FC. So basically, this travels to some cell and it goes like this, right? And now it's bound to the cell. But this piece is sticking up in the air. And now something like a natural killer cell will come along and go, oh, I'm supposed to kill that.
Alright.
So then it, and then it'll eat it, right? That's your phagocytosis. Ow.
So that whole thing is the you said that's the antibody. So that Y is an antigen.
So the Y is the antibody.
So
The thing
Y
it attaches to is the
antibody.
antigen.
The FC
Is a part of the antibody.
and that's the part that does not stick to the cell membrane.
Yes.
It's-
And so the part that doesn't stick to the cell membrane, basically the NK cells combine basically smooth it out.
And then, not even smooth it out, they just go, oh, I'm supposed to eat this.
Yeah, but I mean,
So they take a big ass bite of that whole thing.
okay, so okay. Phagocytosis.
Phagocytosis. But it's not as specific.
What do you mean?
Oh, actually, I'm wrong. This is not phagocytosis.
Normally
Cytotoxicity.
it would be.
Sorry,
so-
no. See, this is why this is the C in acid, because it's cytotoxic. So what these natural killer cells and everything else that reacts and sees that will do is they will release enzymes that will kill that cell. Right? So your cell goes, oh, I know what this means, and then it will release this tiny army of enzymes that will go into the cell and make it go boom.
So the NK cells can get that FC off, but it also release small enzymes to go into the cell membrane to kill the whole cell.
Yes.
So the FC releases is the NK cell release the enzymes or is it the FC?
The NK releases the enzymes, the natural killer cells. And those are toxic substances, hence the name cytotoxic. Now, the third thing that can happen is antibody-mediated cellular dysfunction. So again, mediated by antibodies, but this one is going to cause some level of dysfunction. Now, this doesn't mean it's not making enough. It could mean it's making too much in something like a Graves' disease. Basically, you're not functioning at the proper level. So the antibodies bind, but they bind specifically to receptors. And now that they're on these receptors that are usually used for the cell's function, right? So the example he gives is Graves' disease. So you have the thyroid gland, and you'll talk about it a little bit in, I think you'll talk about it in Path 2, but basically you have TRH, thyroid releasing hormone, or thyrotropin, whatever, being made by the hypothalamus. That TRH will travel to the anterior pituitary gland, and it will stimulate TSH, or thyroid stimulating hormone. And that TSH travels to the thyroid gland, where you create thyroid hormone. Right? So, TSH signals the thyroid, right, that's sitting on your larynx, looks something like this. It comes here, and it binds to receptors, and then that is when you create TH, specifically when TSH stimulates it. Now, there are antibodies that will say, okay, I want to attack these receptors on the thyroid surface. And those antibodies will travel and bind to it. And when they do, the body mistakes those antibodies as TSH. So the antibodies cause overactivation of the thyroid gland. And that leads to a condition known as Graves' disease. Right? Hyperthyroidism.
Antibodies attack receptors causing overactivation of thyroid gland.
Yep.
And then that causing Graves' disease.
Yes. So now that's one that causes increased production. Right? Sometimes it can increase production, sometimes it can diminish production. Right? So on the opposite side of that, you have something like myasthenia gravis or pernicious anemia. So these are the three conditions he talks about regarding this type 2 hypersensitivity. Right? Myasthenia gravis has to do with acetylcholine receptors. So in neuromuscular junctions, if you remember, I guess you're in whatever neuro class you're in now, right? I know you're in neurodiagnosis. Have you guys had CNS PNS yet?
I have.
Yeah, we're in it right now.
So,
I'm going back.
go for it. You talk about synapses, right? And acetylcholine will cross the junction and activate the next step, right?
Mm-hmm.
In myasthenia gravis, the acetylcholine receptors on the other side of that junction are broken down because of antibodies. Those antibodies block the receptors. Right? Put a number on it, and obviously the number should be way bigger, but if I have 10 receptors, normally when 10 acetylcholine get across, it activates. Well, now I have antibodies that block up 6 of them. Well, now I can bind 4 acetylcholine to these receptors. That might not be enough to actually cause the synapse, right? So in myasthenia gravis, the important thing you're going to see is you're going to see weakness that gets worse by the end of the day, especially around the face, because the face has some of the most active muscles in your body, right? So you'll see things like ptosis, which is when an eyelid starts to droop because you lose control of that muscle. You can have diplopia, which is you start to get double vision because your ocular muscles can't work together to keep things in focus. Things like that, right? Myasthenia gravis, no, that's going to be pernicious anemia, which we're going to talk about in a second. So pernicious anemia has to do with B12. Maybe it does have some, I don't know. Myasthenia gravis?
Neurological symptoms as well. So.
But these are more muscular symptoms. But maybe.
Oh, I'm missing something out.
It's not directly caused, but severe untreated B12 deficiency can cause neurological weakness and can coexist with autoimmune conditions like myasthenia gravis.
Okay.
But I would remember that association.
Okay.
Now, pernicious anemia, yes.
Yes.
So, do you guys remember the way B12 is absorbed in the body?
It has to interact with an intrinsic factor, which uncouples it, and then it gets absorbed in the ileum.
Yep. Now, there are receptors in the ileum which allow it to be brought into the intestine at that level, right? Well, in pernicious anemia, what is happening is you have a B12 deficiency in which antibodies block the receptors in the ileum.
Mm-hmm.
And by blocking the receptors, you can no longer absorb B12 deficiency. Or you can no longer absorb B12.
Which
that
leads to
causes a deficiency, right? If you remember, there were two ways you got a deficiency. It was primary or secondary. Primary is you're not consuming it. Secondary is you're not getting it or utilizing it properly. So this would be a secondary deficiency. I'm eating plenty of B12. I just can't absorb it in my ileum because my receptors are all blocked, right? And I talked about Graves' disease, the hyperthyroidism. A lot of the times what happens is you'll see the thyroid gland get larger, right? We talked about adaptive responses in the body to things. If you're overstimulating the thyroid gland, your body interprets this as, oh, we need to have our thyroid gland get larger so we can make more because we want a lot. And then the other thing you'll see on a lot of people with Graves' disease, and this is pretty much the characteristic symptom that you need to identify, is exophthalmos, which think ophthalmic, or ophthalmos. So you have something to do with the eyes. It's not an inflammation because it's not exophthalmitis, right? Exo is outside. So think your eyes are protruding out, right? And that has to do with the same antibodies that stimulate the TSH receptors on thyroid cells attack the extraocular muscle and tissue, and it causes swelling in that region, which causes your eyes to poke out because of the pressure behind it.
Oh. Can we take it? Or, sorry, if when we get... No, it's fine.
Go to the bathroom real quick.
Yeah, that's me as well.
I'll be right back.
Gotcha. Thank you.
Alright, I kind of say that, right now.
Is that your fault?
Yeah, it is my fault. I have to, let it
You
get
gotta do what you gotta do. Mother Nature's a demanding mistress, isn't she?
for work. Not for work. Nice. I just saw one.
Sometimes it's better that way.
Yeah, bro. A lot of times here, but you just gotta look and not do anything about it. Cause I gotta go home. I gotta go home. This class is so fucking hard. You are not lying. It's not even like the class hard. I think it's the teacher that's hard. Because if you were the teacher and you were explaining, well, okay, it makes sense. But he's like,
He's taught it the same way for 100 years.
yeah, all these old ass teachers need to go.
Dude, you want to hear some shit? Did you have Gross One Lab yet?
Nope.
You have an X-Quarter?
Yeah.
So who'd you take?
Pardon.
You want to hear who they had for Gross One as options? One section I saw was Denison and Maine.
Yeah, I did see that. Actually, I may have.
Maine, okay, he's okay-ish. Denison, I would fucking.
I saw one section that was Denison and a Denicon. What the fuck are you learning in that
Oh,
class?
it didn't get. I have her for Gross 2 lab on dry lab. So if you get her for dry lab, she's awesome because she'll only do answers.
I had one of my friends,
But she doesn't know what it is.
One of, like,
Neither does Maine.
one of my best friends down here, his girl takes really good notes. And they had a Denicon. And it was her first time ever doing a Gross 2 lab. And she was like, Lindsay, can you send me
Oh yeah, she sends them out.
Can you send me your notes? And then I'm going to use them to make the exam. And Lindsay was like, sure. And then she just went back and deleted the most difficult shit she had on her notes and then sent it to a Denicon. And that was their test. Like, I watched the Denicon sit there, look at her notes, and be like, oh, okay. And then she'd mark it exactly where Lindsay's picture was.
Mm-hmm.
Actually, I have the first one, Maine and Denison.
Oh, dear God. You're gonna learn nothing.
I mean,
Everything else is full.
yeah, I don't want to change. I'm happy with my schedule. The thing is, I'm learning anatomy for the past like 8 years.
I promise you, Gross 1 lab is a little rough because I mean,
Not with those two.
The who?
with
Who is it?
Denison,
They're
Is
gonna
it-
make it. How much do you think that's?
They're gonna make it. I've heard only Denison and lab is the easiest because you can have.
we
That's
never-
because we
Denison
only had her
has
for
it.
for clinical phys, and that class was a joke. But my point is, I don't think she's ever taught a gross one lab.
That's fine.
I don't think she
usually
knows that
does
much
open
information.
lab, so I don't know.
I can teach gross anatomy. Gross anatomy not that hard to teach.
Well,
Alright.
I know most of it's actually because he gets very,
He's-
Oh,
very
come on.
specific.
He'd be difficult.
Oh,
He's good
he
at.
wouldn't give me that one that branches off the trigeminal because I didn't, or facial, because I didn't
Well, 'cause-
specify that it said facial.
See, that's why I didn't want to take one for
He loves.
Even though he
But
didn't,
it
he
wasn't the
said-
facial branch of the trigeminal. It was the facial nerve.
Well, no, it was the buccal branch of the facial nerve. I put buccal branch and he wouldn't accept it because there's 2 buccal branches.
So corny sometimes.
Okay, that's different. Never mind then.
I lost 1 point in that lab with him.
Hmm?
And I lost 1 point in that lab with him, and it was some bullshit on the first one. Because it was a vocal cords, and I put vocal cords, and he went, well, if you didn't put true vocal cords,
Yeah.
it's technically not correct.
He does sound like that sometimes, doesn't he? All right, you're right. You okay?
Alright. So we have type 3 hypersensitivity, type 4 hypersensitivity, and then autoimmune. And then we're done. So let's fucking
We didn't even finish. We didn't even finish this one today.
Yeah, he went through.
Didn't even finish it.
What did he start
We
going?
didn't finich talking.
We stopped right with the blisters on the wrist. That's what we. Yeah, we stopped right at CTLs.
Is this the last lecture? Because there's,
No, this is week 9. There's 2 lectures for next
well, I
week.
Are you
mean,
fucking
like last
serious?
PowerPoint because we finished on like slide 13.
There's 2 PowerPoints next week, for sure.
You don't happen to have both next week's PowerPoints, do you?
I do.
Could I have
I
them?
have all of them.
Could I beg it?
How are we gonna
I do have
finish
back
that?
tests. I plan on making a big quiz.
Please, please.
He's gonna run through it. What do you mean that you don't know how you're gonna finish it? He's gonna make you finish it.
He's gonna speak really
I don't know
fast.
what class.
He's gonna speak really fast, and you're gonna have to. You've seen that one video of the Russian news presenter where he goes. It's that essentially.
I should just drop, honestly.
It would not be a bad idea. I'm not gonna encourage you to do that,
It's
but
too late now, like, to drop without, like,
I think
You might as well just go ahead and take the final one.
you're better off taking it.
Yeah.
you talk with your advisor. Ask if a WF is better than just an F on your GPA.
Also a fair point.
I mean, I gotta take it again no matter what. I don't give a fuck about GPA.
You should.
better-
You should.
Yeah.
Why?
Because this class would kill your GPA the way it's doing with mine.
Unless you have A's
Alright, Big
in
Red,
all
open up
your
your
other
airdrop.
classes
Yay!
right
Thank
now,
you.
Then, unless you have like A's in all your other classes,
I am open,
really
thank you.
try to get as much as you can, because that fourth credit will kill you.
Big Red.
That's week 10, lecture 1.
Oh my God, that's wonderful. I'm going to go
And then
read
here's
through all of
week
this.
10, lecture 2.
Blessed.
I hate how
Blessed.
he doesn't listen to something.
Yeah, that
What
is.
is it? I don't have his. I have the old ones.
This
I
looks
have
like this.
Sunshine's.
Looks like these.
Do you want to send them to you too?
I'm just gonna wait for you to put it on your
Uh,
top. I'm wired.
What's your airdrop code, Fancy Pants? KGB Security.
KGB security.
I don't know how to do this. Oh, it's 670-523.
523?
oh my God.
She said it.
What?
6, 7.
Oh my god.
And then
It's
there's
the new
second one.
69.
69 was never this fun.
No,
You know, you're right.
738.
Okay, Fetty, chill out. Okay.
Did you just call her fatty?
Oh, I said
No.
Fetty.
Yeah,
Fetty
sure. You.
Oh. Chill out. Alright, so do you guys want to run through the last of this stuff?
It would not hurt.
It shouldn't take long. So type 3 hypersensitivity, immune complex mediated. Wake up.
Go wait. Let me dance.
There.
Immune complex mediated.
Immune complex mediated. So remember what an immune complex is. It's an antigen and an antibody. What are you putting your hand up for?
He did
I
actually.
just started. How are you confused?
Well, no. He did actually get to a little bit into number 4. So this is type 3 is. So you were there for that? Okay, good. Gotcha. Okay, I thought you said we weren't. Okay, whatever. Fine, go on.
Okay.
Immunopathoimmunodiseases.
So,
That's where he stopped.
type 2 hypersensitivity. We were talking about immune complexes that form. However, they formed on the surface of cells because that's where the antigens were. In type 3 hypersensitivity, what happens is the antigen and the antibody combine in circulation, and then that complex later deposits somewhere in tissues. Right? So I'll say it one more time. Type 2 hypersensitivity. Your antigen was already in the cell membrane, and your complex formed when antibody traveled to it. In this case, your antigen and antibody are free-flowing in the blood. They meet in the blood, they create a complex, and that complex as a unit is what deposits on cell surfaces or tissues later on. Right? Now, most of the time, that deposition, the cells or tissues it deposits on, is going to be the walls of the blood vessel. Because it happened in the vessel. That's where they met. They were both in circulation. Now, at this point, we have the same sort of thing happen that happened in type 2. You have a phagocyte that finds these complexes and will try to remove them.
The antibody antigen complexes.
Yes,
So phagocytes try to find antibody antigen complexes.
that are embedded in the vascular wall at this point. Right? So you have a complex in the vessel wall, the phagocyte comes to try to destroy it, and then it realizes, I can't eat my blood vessel wall because it's attached to the vessel wall, so I cannot get around it. So this leads to frustrated phagocytosis again, right? Rather than try to eat it, I'm just going to secrete some stuff to try to kill it and damage it. There's just one problem. It will not be specific to the immune complex. it now damages the vessel wall.
Oh, then thrombo happens. Yay!
It tries to consume it, it tries to phagocytose it, but it can't because it's too big. So, there's your frustrated phagocytosis. Now, if you have enzymes and toxic chemicals that are attacking the vessel wall gets inflamed. When you have inflamed vasculature, determines vasculitis. Remember, itis, inflammation. Now, this happens in a couple different diseases that he talks about. The first one is acute serum sickness. So acute serum sickness, basically, you take a large amount of serum from some sort of, so this one typically you do in something like a horse, right?
Yes.
You don't do this a lot in humans, but you take a large amount of serum that's foreign, right? Serum is blood plasma that does not contain clotting factors, and you administer that serum, and that's typically you administer it for the point of immunization.
So just take a large amount of blood plasma and just stick it into something else.
Yes.
From the same
Because
species,
that
from
blood-
horse to horse, or from human to horse? What's going on?
Horse to human was, I think, the first.
Good lord, what?
What are you talking about horses for?
Serum sickness.
I thought he was misspoke when he said that.
No.
Good lord.
Human horse.
So we wait for the horse to develop the immunity, and then we take the horse's blood plasma and put it into ourselves?
That's what his slides say.
What?
What the hell? I mean, I guess that makes sense because plasma is technically universal, but still, is plasma universal? Hold on a
If I
second.
left
Yes.
my water bottle in that class, do you think that
Yeah, it'll still be there.
Okay.
So tetanus antitoxin is a equine blood origin product. They prepared blood of healthy horses that were hyperimmunized with the tetanus toxin, and that serum was then injected into humans.
So is that how? Remember when COVID was a big thing? When people saying using horse tranquilizer, or horse something. I know you know what I'm talking about.
Yes, I know what you're talking
People
about.
try to use
Yes.
horse, like.
Well, that was
horse-
different. That was just
See, okay, now we're getting into Mr. Hands territory.
But to say, I'm not tripping. You know what I'm talking
I know what you're talking about, but we're getting too close to Mr. Hands at the moment. We don't need
Mr.
that.
Hands.
Look it up, the Mr. Hands incident.
But
He
this
was a
is gonna
Boeing
be-
engineer.
So this is a passive immunity, right? So passive, your body's not doing any work. So basically, what happens is you have a horse. You keep injecting the horse with tetanus, right? Well, in response to the tetanus, the horse will create antibodies against it, right?
Mm-hmm.
So now their immune system produces high concentrations of antibodies that are released into the blood of the horse. You then collect the blood of the horse that is rich in these antibodies, right? You take that plasma, you take the clotting factors out, now it's a serum. You separate and you process that blood into an antitoxin. Now, if I have a tetanus, like I step on a rusty nail, right? And I need tetanus, what it used to be was they would give you this passive immunity tetanus toxoid that stimulate active immunity and help fight off the tetanus, right? But there was one problem with that. Well, there were multiple
God.
problems with that.
Yeah.
But one of the major problems with that is the body would sometimes react adversely to the fact that you just pumped it full of antitoxin from a horse.
No. Wow.
This is
So-
a real thing?
Yes. So this is broken down into 3 phases. In the first phase, the antigen present in circulation is reacted to by the antibodies produced from the foreign serum. Right?
So repeat that. Oh,
Is this not on your guys' slides?
No.
I'm not looking at the slide. I'm not looking at the slides. I'm looking at Quizlet.
Wait, did you guys not learn this?
No, he briefly mentioned horses and putting things into a horse, but I don't think he mentioned.
I don't know what you're talking about. Horses,
Slow down.
man.
That one. Systemic immune complex disease, acute serum sickness. large amounts of foreign serum. Horse anti-tetanus serum is the example of this. So, ready? We're gonna run through this one more time and try to help you understand it.
Oh, I was not in class today when that was going on, so that's why I'm like.
So,
what?
horse, you have a horse. You're injecting this horse with tetanus.
My favorite.
Like, gotta be a
It's not for a horse.
Well, so
Would you
this
rather
is,
inject a person
it was
with
the
it?
inactivated form of the toxin. So, as I said,
We're talking about horses.
it was the inactive form of the toxin, right? So the horse was fine. But basically, the horse immune system would do the same thing the human immune system would do. We weren't allowed to experiment on humans. And it would create antibodies,
Thanks, Hitler.
right? It creates antibodies for tetanus, right? So now the horse has a bunch of antibodies in its blood. So now we draw the blood from the horse. And when we do that, we get a product that is really rich in tetanus antibodies.
Yes.
Well, that's a good thing, because now our body doesn't need to create the antibodies. You can just give them to me, and they're preformed. That's passive immunity. Right?
Mhm.
So now you inject a human with these antibodies, and they do an immune complex mediated reaction, because the person stepped on a rusty nail, and now they have tetanus in their body. You inject them full of these antibodies. The antigen and the antibody combine and form antigen-antibody complexes, right? Immune complexes.
You got passive immunity example, inject horse with tetanus into a horse building up antibodies. You take those antibodies,
You stick them in a human.
stick them in.
Yep. Now, that human had tetanus. So the antibodies from the horse that were created in response to tetanus do the same thing in the human. They will bind to the tetanus toxin, right? And they form immune complexes. Remember, this is immune complex mediated. Well, so in the first phase, what we're talking about is you have antigen antibody complexes that are forming. That's that. Just that last step. You
So
follow?
the antigen antibody complex is an immune complex mediator.
So it's an immune complex.
So this is the immune complex.
This is an example of an immune complex mediated reaction. Yes. Now in the second phase, what happens is the complexes that formed will begin to deposit in tissue beds around the body. Some of them are the heart, the skin, small blood vessels, whatever. You end up seeing a rash occur. Right? And that's what happens in the third phase. So you had complexes form for the first phase, complexes deposit throughout the body for the second phase, and the third phase is the activation of complement in response to these complexes. Right? So during this phase, your body is trying to break down the complexes. So you get things like a fever, a skin rash. You may see enlargement of the lymph nodes. You may see proteinuria. You may see arthralgia. Now, the reason you see things like proteinuria is because these complexes may deposit in the kidney filtration units, causing damage to the filtration unit, allows protein or larger molecules through that shouldn't get through otherwise.
Rash, fever, enlargement of lymph nodes, proteinuria, and what?
Lymph node enlargement, which is just classic infection, and then arthralgia is the other one. So it's joints, yes, because if the immune complex deposits at the joint, then your body attacks it, right?
How's that passive though? I feel like this is all active.
So passive was just the act in which you were fighting off the tetanus. If you remember from microbiome, there were 4 ways you could immunize someone. They were active, passive, natural, and artificial.
Okay, I do remember that.
You could have active, passive, active,
Yeah,
passive.
I do remember that actually.
Active artificial or passive artificial, active natural or active or passive natural.
So
or whatever.
passive is just
So natural passive was like your mom has the antibodies and she gives them to you. So now it helps your immune system. Active passive or active natural was you make them yourself.
Does he break it down like that?
He doesn't.
So
This is what Dr. Lou is supposed to do.
No, it's just worms.
Passive, so passive immunity is just fighting tetanus.
Okay, so you have active, you have passive, you have natural, and you have artificial. Right? These are your four kinds of immunity. So, for passive natural, you're thinking mom gives it to the kid, right? So now we're talking about the kid here. The kid did nothing to develop this immune response. It just got it, but it got it naturally,
Oh, okay.
right?
Yeah.
Now you have
Horse's mom.
passive artificial. Well, this is going to be the horse
Mm-hmm.
gives it to the kid. Not through the blood, because you inject it, right? It's artificial. This shouldn't happen normally, but it does. It's artificial, and it's passive because I didn't have to make the antibody. The horse did, and I got it. Right? And then you would have natural active is like you're exposed to something, and then you create it, right? That was like a type 1 hypersensitivity. We talked about you're exposed, you're sensitized. This is also like you get a flu. Your body creates antibodies against that flu. Now you're technically immune to it, right? Active immunity.
And like TB. You're exposed to TB and you get TB.
Yes, but this is like immunity. So this would be you get something, you recover from it, now you can't get it anymore. It's like chickenpox. Granted, you talk about shingles like one.
Yeah, like does it
So like chickenpox. So back in the day, before there was a chickenpox vaccine, I don't know if you ever heard this story. My mom told me this story when I was a kid. Back in the day, if you had a kid that got chickenpox, you had a party. You invited all the kids from the neighborhood over, so all of them could get chickenpox and get it out of the way, and now everyone was immune to it.
I've never had it.
And then they were like, "Oh, let's make a vaccine," and then they made a vaccine, and then that didn't have to happen anymore.
Just
But
one
like
more
my
social
parents-
circle we don't
My
have
parents
anymore.
did chickenpox parties.
Did they have chicken? Did they at least have chicken?
Maybe.
They had to have chicken.
But that was the procedure people used to do because it was going to spread no matter what because nobody was vaccinated for it. But if we just all get it and get over it, now we're all immune to it, right?
Imagine not having those sticks.
It's like the idea of herd immunity. Have you heard herd
Yeah.
immunity where if you have enough of the population immune to it, that is something that usually happens active naturally over time. You become immune to it. And then you have active artificial, which is when you inject someone with like a very low dosage of a certain antigen.
So like which one?
Yes. And then your body creates the antibodies. It's active because I'm creating it, and it's artificial because I didn't naturally get infected. But yeah, so acute serum sickness, the mechanism of using the horse blood or the horse serum with antibodies is a form of passive artificial immunity.
Gotcha. And you said there were 3 phases of horse blood. What are those 3 phases?
I didn't say there were 3 phases of horse blood. I said there were
Can I explain it?
3 phases of serum sickness.
Oh, gotcha.
Let's hear it.
So the way he explained it was, you have a horse, right?
Mhm.
You poke the horse a lot with a disease like tetanus, right?
Okay, I get that. Okay, I thought that was a different subject we were moving on
on the
to.
roll, man.
No, you're good. Keep going.
And then so you poke the horse with tetanus, the horse builds immunity from it or antibodies for the tetanus so it can fight it.
Mhm.
We say, oh, you're fighting it, we want to take it.
Gotcha.
So we take it as humans, we don't give. So we take that, right?
And we give them tetanus.
Yeah,
Okay, excuse me.
It's called pistols. We love them. And so we take the antibodies and then we inject them into our bodies, right? And then that antibodies attached with antigens will build an antigen-antibody complex. And that complex, it gets deposited in tissues in our body like the heart, the joints, the lymph nodes, and all
The
that.
kidneys.
The kidneys. And when that happens, that either has a rash, an enlargement, a proteinuria.
Now you get your immune response.
Right. This is what I wanted. This is what I
That's
wanted.
the third part.
Arthrogenetic, I don't know, arthogenetic what is like arthritis, for the joints.
Okay, so say all three of those again real quickly, please.
Okay.
Makes rash occur, lymph node enlargement, proteinuria, and then arthritis.
Okay, say it again, but a little slower, please. Rashes.
Rash occur,
Mhm.
lymph node enlargement, proteinuria, and arthritis. And that's the third phase. The first phase is immune complex. The second phase is,
First phase immune complex is formed.
and then the second phase is complex form deposits in tissues.
Yep.
And the
Deposits.
third phase
And
is
the third is the actual reaction.
a reaction to it.
Okay, so immune complexes form stage 1. What's stage 2?
The complex has formed is deposited into the tissues around the body.
Oh, okay, gotcha. Okay, so it's okay, gotcha. Okay, I thought they were.
And then
Moving
the
on to the
third
next.
phase is basically what happens from
Yes.
doing that motion.
And that is type 3 hypersensitivity. That's what pretty much all of these conditions that you talk about are going to end up doing. So, the next one he talks about is Arthus reactions, which are local immune complex diseases. So, acute serum sickness was everywhere. Arthus reactions are localized, specifically to the site of injection. Basically, you inject an antigen somewhere, right? For now, let's say we do it right here on my forearm. Boom, antigen's in. Well, I've previously been exposed, so I have antibodies that are freely circulating throughout my body, waiting to see this antigen again and attack it. So, immediately upon this antigen entering my body binds to it and forms a complex. That immune complex then deposits around the site of my infection. Right?
Mhm.
Now, I will see edema, hemorrhage, ulceration, anything of that nature. Usually it peaks 4 to 10 hours after your injection, and it is specific to the injection site. So whereas on the last one, it was, it entered the blood and it was anywhere in the blood at any given time, right? This one, it's specific to wherever I injected my antigen, is where I'm having an allergic reaction. And then the last one is farmer's lung, which is a specific type. So this is hypersensitivity, pneumonitis, inflammation of the lungs, right? This is going to follow that same sort of path as Arthus reactions, but this is specific to I inhale something like a dust, right?
Mhm.
Hence the name farmer's lung. They would inhale things like spores and dust while working on the farm, and it would cause a localized reaction in the lung wherever that pollen or that spore or that dust, whatever it may be, deposited in my airway.
Mhm.
And then we have type 4 hypersensitivity. So type 4 is mediated by T cells, not antibodies.
Is that delayed?
That's delayed. So this one's going to take time. So,
What's your reading for this?
what do you mean?
Because when you wrote, I have it as type 1 is allergic reaction, type 2 is antibody mediated, type 3 is antigen antibody combined, and then type 4.
He calls it cell mediated, but it's going to be T cell mediated. But now this one is usually the one that takes a little bit of time, right? So these are T cells that have been sensitized. If you remember T cells, they can become cytotoxic T cells. They can become memory cells, right? Memory cells stay in your body for years and years and years, and they will react if you're exposed to something similar again. That is involved in this type 4 hypersensitivity. It's not antibodies, it's a little more specific. Now, guess what takes longer to create?
T cells.
Sensitized T cells or sensitized antibodies?
Antibodies.
No,
T
they're
cells.
quicker.
T cells.
So
T cells take way more time to make.
And then the T cells become memory cells,
And
which
T
live
cells
far away.
mature
And then the-
into memory cells.
And they mature into memory cells inside the lymph nodes.
Thymus and all that.
Ah, fine.
Now you have it.
Say it again. thymus and lymph
They
nodes,
mature
or
in the thymus, enter the blood, and then usually they'll mature in places like the lymph nodes, because that's where a lot of the bacteria ends up being.
they are created in the thymus and then mature in the lymph nodes, or is that
They mature in the thymus before they're ever released, but they become memory T cells in the lymph nodes.
that's what I wanted to hear? Okay.
But you have two basic types of type 4 hypersensitivity. You have delayed type hypersensitivity and direct cell cytotoxicity. So, delayed type, this is initiated by CD4 T cells. So CD4 plus T cells were helper T cells. Helper T cells could become a couple things. One of them was memory cells. So basically, your CD4 cells release cytokines. Remember, cytokines were signaling molecules that would stimulate certain pathways in the bone marrow, right?
Mhm.
One of the things it would lead to is recruitment of macrophages. And the macrophages are what respond in this case and cause damage.
All right.
Direct cell cytotoxicity uses CD8 plus T cells. CD8 T cells were cytotoxic T cells, right? They are directly attacking things. So they will destroy abnormal cells through two mechanisms. And this is going to sound a lot like previously when we talked about type 2 hypersensitivity, right? You had lysis and you had opsonization. But those were directed by antibodies. This is the exact same thing. Osmotic lysis and apoptosis, but it's done through T cells. So either you're directly breaking it down, or rather than phagocytosis, you have apoptosis. So the cell is being programmed to die.
This is CD8, right?
Yeah, that's CD8, or cytotoxic
And you
T
said,
cells.
can you explain CD8 one more time real quick?
CD8 is just cytotoxic T lymphocytes. So they can secrete enzymes, like lytic enzymes, that will break down things. So normally you will destroy the abnormal cells with two mechanisms from those CD8 cells, either osmotic lysis or apoptosis. So, we talked about mediators that were preformed inside of cells. One of them was histamine. These cytotoxic cells contain two mediators that are preformed, perforin and granzymes, right? So now what do they do? So, perforin, think of perforating, right? It's making holes. You ever have one of those notebooks that you can tear the paper out of, not through where the rings are, but you like fold it and there's a little edge? That's a perforated ring notebook. Does yours have it?
Yes.
Yeah, you see all those little holes? That's a perforated notebook. So what perforin does is it forms perforations. So you have a cell like this, right? This cell becomes infected. That's bad. So the T cell comes along and it releases perforin. And perforin does this. Those are a bunch of holes. It has perforated the cell. This happens in either osmotic lysis or apoptosis. Both of them, this is true. Your perforin will create holes in the cell membrane. Now, what happens from here is one of two things. Number one, you have water that enters the cell from those holes. Right? Water enters, it fills this cell up, it increases that internal pressure so much that the cell blows up. There's your lysis. That cell is now broken down. Right? Now the other thing that can happen is you have these holes from the perforin. Now those holes, in the first example, water entered through them. In this example, you have granzymes entering through them. And what granzymes are is they're little enzymes that will go into the cell and will signal cell death. So think about the fact that every cell kind of has like a self-destruct mechanism, right? Granzymes will go into the cells through those pores created by the perforin, and they will activate that self-destruct mechanism. They will signal the cell to kill itself. and that is how the cell dies.
Damn.
Yeah.
Shit. So granzymes enter signaling cell death, causing suicide.
Yes.
And the other one is
And they enter through the holes made by the perforin. And the other one is perforin, which makes holes. And then those holes either allow entrance to granzymes or excess water. And if it lets in excess water, the cell blows up. If it lets in granzymes, it causes apoptosis.
so apoptosis is granzymes, and then
Osmotic lysis is water entering through the perforin pores. Now he talks about 4 different type 4 reactions. I have 2 that I wrote down based on sunshine slides. You'll have to let me know. Did he get this far?
No.
Okay.
stop.
Oh, he stopped at month 2.
Mountain 2 test.
Yeah.
Cool. So I'm going to mention these. If he brings them up next week, great. You can hear it a second time. If he doesn't, forget I said it. So you have a tuberculin reaction or a Mantoux test, what we were just saying. This is used to screen for individuals who have been exposed to tuberculosis previously, or they carry the tuberculosis bacteria or antigens without realizing it, right? Basically, you inject the person, and after you give them that injection of the tuberculin extract, the area you injected will become red, swollen. It'll be relatively small. Basically, it just shows you that what you injected them with, there was something in the body that reacted to it, right? So, for example, if I had previously been exposed to TB, I had antibodies now to TB. That TB gets attacked.
Where you at?
Type 4 and 100%.
8 to 12 hours after intracutaneous injection of tuberculin, local area of erythema and induration appears, reaching a peak.
Okay, so you're off the PowerPoint now.
No, I'm on the PowerPoint. Is that not on your PowerPoint?
It is.
Where do you see 8 to 12 hours now?
There's a little arm. There's like 4 forearms, or 3 forearms on it. Go up. That
Oh, this one?
Yeah.
Oh, okay. See, I was going down. You skipped and then went back.
Did I?
On the way you explained it, yeah.
My bad.
Not your phone. Putin doesn't like.
So tuberculin reaction, the circular area gets red, right? And that just tells you that there was some sort of memory in your immune system to that bacteria before. Contact dermatitis, this is, think your poison ivy, your poison oak. So the active component in those is known as urushiol, right? If you think about it, when you brush up against poison ivy or poison oak, it takes a little bit of time before it sets in the fact that it's itchy, right? Before you realize what's happening. That is contact dermatitis. It is a type 4 delayed hypersensitivity. I don't think he's going to ask any of these bullshit questions. So, now the other 2 that I have written in my slides are Stevens-Johnson syndrome and Lyle's syndrome.
He's not mentioned those yet. If they're on the PowerPoint though, there he's going to mention them. So,
I don't think they are.
1 moment.
He said Stephen Lyles.
Stephen Johnson and then Lyle's
That's
syndrome.
it's spelled it's Stephen.
Stevен.
V-E. Nope, I'm not seeing a lot of Stevens here.
Now, Sunshine wrote it, and a lot of the times when she writes things, it's because he says them in class. So, I'm going to run through these real quick. If he mentions them, great. If he doesn't, whatever. Stevens-Johnson syndrome is you have epidermal cells that are attacked, or so you take an antibiotic. Antibiotic binds to epidermal cells, those skin cells, right? And then you have a skin reaction. So this kind of goes back to what we talked about, the drugs. This is that same sort of mechanism. And then Lyle's syndrome is just when it gets worse. So Stevens-Johnson, you see manifestations in the skin like a rash. Lyle's syndrome, your skin literally starts to detach from your body. It's disgusting.
Lyle's syndrome. 1 second.
What is the DTH under hypersensitivity form?
Where?
A special form of DTH occurring in studies.
Delayed type hypersensitivity.
Is it Lyell?
Lyell.
Oop, shit. I mean, don't say that. Don't say that.
And then the last thing we have to talk about are going to be autoimmune conditions. So autoimmune conditions are when you attack yourself. You have autoantibodies involved in this. They are antibodies formed against cell tissues. Commonly, this happens and it targets connective tissue, and you have connective tissue everywhere in your body. So it can manifest in a million different places. The 4 that he mentions in his slides, you have systemic lupus erythematosus, which he absolutely loves. This is when you form antibodies against nuclear components. So components of cell nucleus, right? Those are known as ANA, anti-nuclear antibodies. So you can target different portions of the nucleus, right? You can have anti-dsDNA, which is double-stranded DNA, or you can have anti-Smith antigens, which is just another protein within the nucleus. Typically, in systemic lupus erythematosus, you will be anti-dsDNA positive and anti-Smith positive.
Okay, no, so say those 2 things you could have in the
Anti-dsDNA,
anti-DS?
dsDNA,
DS.
which stands for double-stranded DNA, and then anti-Smith. So both of those are autoantibodies formed against components of the nucleus. Now, this can affect anywhere in the body, hence the name systemic. It can be the kidney, the lungs, the brain, and the skin. You talked about it in the kidney specifically. The most important thing to know about systemic lupus erythematosus is the butterfly skin rash. Patients present with a rash across their cheeks, across their nose, and across their opposite cheek, almost like a butterfly landed on their face. All right? It typically spares the forehead. It typically spares the chin. Usually, it's just the eyes and the cheeks and the nose. It used to be really deadly. Now it's not anymore. Who cares? It's a history lesson. Systemic sclerosis or scleroderma, scarring of the skin. Right. This is an autoimmune disease, and basically you deposit way too much collagen in the skin, which causes hardening, scar tissue. Right. All of your skin now is becoming scar tissue. That's not good. The primary place you're going to see this is on the face and the hands. It's described as a mask-like face and claw-like hands. Not just skin, it can also affect organs because connective tissue and collagen is also in this organs as well, especially the lungs, the kidneys, and vessels. So these are things that normally are flexible. If you put scar tissue there, it can interfere with function. The sclerosis can be described as either diffuse or limited. Diffuse is less benign, which means it's worse. I don't know why.
Why would he just say less benign? I mean, is that a specific word for cancer metastasizing?
So I think it's because systemic sclerosis and scleroderma isn't that big of a deal. However, diffuse scleroderma is technically more dangerous because it's already everywhere in the skin, and now it can involve your organs very easily.
All right, so you said
Limited or localized scleroderma is more benign, meaning it's better. Typically, you see the characteristic CREST syndrome, C-R-E-S-T, which consists of calcinosis, which is calcium deposition in soft tissue without inflammation, because it ends in osis, not itis.
localized. I don't know. Localized. Where'd it go?
Localized scleroderma is more benign, and it's characterized by CREST syndrome, C-R-E-S-T.
Localized scleroderma. Okay, that's it. Okay. Localized scleroderma is manifested by what now?
CREST.
CREST. C-R-E-S-T.
C stands for calcinosis, calcium deposition without inflammation, because it's not calcinitis, it's calcinosis.
Deposition just means it's been put in the
Being
body.
deposited in the soft tissues. So this is when it'll start to appear on X-ray, right?
Mhm.
Usually soft tissue on X-ray is a dark color. If you add calcium to it, it'll become more white because it's metal. Raynaud phenomenon. We talked about Raynaud syndrome, where you have vasospasm of the finger vessels, right? You have that color change. That is something you will see in limited
So just color change of the skin.
You'll see white to blue to red. It's vasospasm of the finger vessels. He loves Raynaud's.
Yeah.
He loves Raynaud syndrome. I think he dreams about it. Know that it is white to blue to red. White, because you are not getting blood there because the arteries have been cut off.
Blue because it's
you are losing
hypoxia.
the oxygen. Red because they relax and blood gets to rush back in.
Yay.
Think about when you're out in the cold. Your fingers get white. And when you come back inside, your fingers get red as the blood comes back. Well, they never turn blue
Because they're not hypoxia.
because they didn't lose all of the oxygen. Because if they do, guess what? Now you're going to get frostbite. Right?
I got that once.
And then your ES and T in crest is esophageal dysmotility. So the motility of your esophagus is not operating the way it should.
Esophageal what motility?
Dysmotility.
Dysmotility.
Which gives you problems swallowing because now the muscles in your esophagus aren't acting properly, right? You have sclerodactyly. Dactyly always includes fingers. Sclero is scarring, so you see scarring of the fingers. Now, a lot of times you'll see this turn into gangrene because your fibrous deposition will completely destroy the capillaries of the finger and cut off oxygen and blood supply. So it leads to necrosis. But sclerodactyly, scarring the fingertips. And then telangiectasia, which is spider veins. So think of a little spider web. Now imagine if that were blood vessels. Yes. Like I said, the most important thing you need to think about is mask-like and claw-like hands that develop during scleroderma. You have dermatomyositis and you have poliomyositis, or polymyositis, which is a different kind of autoimmune inflammation. It's inflammation because both of them end in itis. Dermatomyositis, derma of the skin, right? So it's inflammation of the skin. Polymyositis, myo is in muscle, poly as in many muscular inflammation due to an autoimmune condition. If you are attacking the muscles, odds are you're going to be getting progressively weaker because you are slowly breaking down your muscles. So you get things like atrophy with progressing weakness and loss of muscle. And typically it's going to be symmetrical involvement because it's autoimmune in nature, right? Typically you'll see proximal muscles get affected first, which is opposite of what a lot of other conditions you guys have talked about do, right? This starts closer to the body and extends out.
You said that was dermato something.
Dermatomyositis and polymyositis. Typically they happen together. Now this gets really dangerous when you invade breathing muscles, like intercostals, because now you can't breathe properly. Now you die. Think of polio. 60% of the time, dermatomyositis and polymyositis end up developing into paraneoplastic reactions or tumors. That's not good. Tumors are bad. Generally, they're pretty malignant, meaning they can travel throughout the body.
You know what's crazy? This answer for syndrome was on the
Sjogren's? He talked about it previously.
He didn't talk about ulcers as part of it, though, did he? Because that was the question.
He definitely, I remember talking about it because your eyes get really dry. And then you can rub them raw, so you get ulcers.
What were the names for those tumors you just mentioned?
Paraneoplastic reactions.
Corneal ulceration. Yeah, no. That was, it was like, which one of these causing corneal ulcerations?
That's great. So, the last condition is Sjogren syndrome. So we talked about this once before. It is the autoimmune destruction of exocrine glands, which are responsible for production of fluid. So, if you have Sjogren's syndrome, you are dry in places you should not be dry, like your eyes, your mouth, your gastrointestinal system, right, lining your organs. So, those dry areas can lead to your complication. If you have dry eyes, it can lead to corneal ulceration. That was one of your quiz questions. Think the fluid that usually goes on top of your eye reduces the friction of it. If you dry your eyes out, you rub your eyes a lot, now you may scar the cornea, right? If you have a dry mouth, it can lead to tooth loss. You've probably heard of the word gingivitis before, inflammation of the gums. If you're a mouth breather and you snore, like I do, you're more apt to get gingivitis because you dry out the gums. Now, if you allow that to be too severe, in a case like Sjogren's syndrome, you can actually lose your teeth because your gums will experience so much damage. Sometimes you can get joint pain here. It's not super common. It's not one of the characteristic symptoms, but Sjogren's syndrome is a rheumatic disease, similar to something like rheumatoid arthritis. So it can present with arthritic symptoms. But the important thing, dry eyes, dry mouth, zero ophthalmia, zero stomia.
Hold on, 0 ophthalmia and 0. Hold on a second, where did that go? Ophthalmia and 0 stoma.
Yep.
This keeps coming back up. These things keep coming back up.
Well,
Zero
yeah.
ophthalmia and zero stomia? Yeah. Sjogren's syndrome, he loves it.
Not just this class, I feel like it came up before in other classes.
It
So-
will in the-
You're going to hear a lot of this shit in UA too when you get to clinical